CBME specifically stands for Competency-Based Medical Education, and of course the specific program that the Royal College has come out with is what they call Competence by Design, or CBD. And really the idea and the initiative behind CBME is really to get more eyes on our trainees as they go through, just to ensure that we're actually observing them and that they're having their skills as they come through. That's on a very basic level, but of course it does seem like more of a fundamental overhaul of the whole system in terms of how we actually progress our trainees from the time they start the program and how we actually prepare them for practice. And that's what I usually tell most of our residents, that at the end of the day, CBME is not something to be scared about. It is a transition, but like all good things, there's an opportunity to look at things that actually work and say, how do we actually make them a little bit better so that we can continue to make sure that we're training our trainees to be ready for going into practice in the future. So one of the opportunities and changes that's happened with CBME is that they basically looked at the idea that rather than taking residents and saying that if you spend this much time in a rotation, you are considered to be competent, and then you have some sort of major summative evaluation near the end of the rotation, we feel that there's a lot of missed opportunity there for kind of getting a little bit more feedback, a little bit more what we call formative assessment from your facilitators. And so the idea is to bring in a little bit of a coaching mentality into our teaching, such that we can actually get our eyes on our trainees both within the room and also within the clinic, and try to provide feedback more in the moment to try and help them grow into the role and to effect change. We're very fortunate at Western, and we've actually been espousing these principles for quite a long time. I think one of the things is that while we can paint CBME as being something new, really what we're doing is taking structures that are already in place and just trying to finesse them a bit more to allow for more formative evaluation. We benefit a lot in Western from having a very good staff to student ratio. So basically we have about 20 staff, and we usually have a maximum of 10 residents within the program, of which only usually 6 to 8 are on rotation at any time. And so that really provides an opportunity for us to have a lot more hands-on interaction with our trainees and to get to know them really well, and to also understand both their strengths but also areas where there might be potential for improvement. The other thing that we've been doing, although CBME was brought in for the formal cohort of residents starting in 2019, we've actually been using the tools and bringing the tools of assessment into our program really since 2016. We've started to kind of build them into the program and to get our staff familiar with using these tools to better help provide quality feedback to our trainees. So I think at the end of the day, when we look at where CBME starts and where it ends, I think we'd be fooling ourselves to think that it is exactly a rigid one-way system, that the way it looks today is the way it's going to look 5 years, 10 years, 15 years from now. It's a construction project, and I think the idea is that we're all going to grow with it and through it together. One of the things that really helps me is I know that over the last number of years, we've been graduating and putting into practice competent physicians from our program. We know that just by looking at our track record. The students who come through our program, who turn into residents, who turn into staff, pass their exams, they get jobs, they do very well, and they also tend to succeed even after in their careers in terms of academic output and taking on trainees of their own. So I think the legacy of the London program from an educational point of view is really strong, and so it encourages us that we've been doing something right. I think we have an opportunity to take that and mold that now as we go forward into something that will really benefit our trainees. For competency-based medical education, one of the strengths is actually that there's a variety of ways in which residents can actually be evaluated and can gain both formative feedback and also kind of opportunities for coaching so that they can grow their skills as time goes on. What used to happen is that you would spend a few months in a rotation with the staff. At the very end, you would meet with them and they would have an evaluation about how things went, and it would be generally an overview, or what we call a summative evaluation, of kind of pass-fail. And I think we want to move away from that, rather to the idea that each time you spend time with the staff or you do a clinical task or a skill, there's an opportunity for growing a specific skill or an assessment or a bit of coaching that can happen. One of the frameworks that has been brought in by the college to kind of help with this is the idea of the different stages of progression through residency, starting off with transition to discipline, foundations of discipline, which often lines up with where a junior resident would be, the core skills of the discipline, which is really what we would often have thought of as being a senior resident skills, really the core discipline-specific things related to radiation oncology, like contouring, seeing patients in consultation, designing treatment plans. And then ultimately a final stage, which I think is really fruitful, which is a transition to practice. How do you take the skills you've learned and start functioning so that you can run a full practice and function independently outside of a training program? Each of those stages has different entrustable professional activities, or EPAs, associated with it, which are basically the core skills or activities that will be required from a radiation oncologist to be considered competent in that specific area. And they're broken down a bit further into specific milestones. And so the evaluations that are ultimately available electronically that are done with your staff are to basically judge various aspects of those milestones, which can lead to the completion of an EPA. To make it a safer environment for a trainee, one of the important things to recognize is that the staff that you work with, and this is very critical, no longer is the person who ultimately decides if you pass or need to take a little longer into a rotation. The idea is that you continuously learn as you go forward, and then we have a competency committee that actually meets every 3 months, sort of on a quarterly basis, and we review the progress of each of our residents, just seeing how are they doing, where are they excelling, where are some of the areas where we might need to give them some more opportunities to make sure that they're working on their milestones, such that we're ensuring that all their EPAs get completed on time and that they can progress at the appropriate level on time. It's an opportunity generally to allow us to ensure that residents who are proceeding in the right manner. Most times, if you have a resident who's excelling or doing well, it provides us an opportunity to further that and pick up some other areas where we may have just said, oh, that's an excellent resident, we have nothing more to see, but we can actually kind of use that to make them, outstanding. For those who might be falling a little bit behind in some domains, it gives us a really early opportunity to intervene and say, how do we best help that trainee get to where they need to be? So I think ultimately the idea of taking the task of evaluation and progress from the resident and disseminate it amongst multiple staff, multiple physicians, facilitators, educators, and also putting a little bit more of the impetus on the resident as well to be self-reflective and learn where they are in their training, I think is ultimately an empowering thing for the resident, and I hope that that's how we'll see CBME blossom into as we go through this transition in the next few years.